When you think about organizing a collaborative for this, both Marc and Mai, what's needed at this point? So you said you haven't moved quite to a clinical trial, but let's say you move to that direction next. I would think you'd need many, many centers, many patients. At least looking at this, I imagine it's going to be in the hundreds of patients, you think? Or would you do a pilot just to get up? I mean, it sounds like you've got proof of concept already, but you'd want to do a short, small pilot or something like that, you think?
Yeah, what we're collecting now is the willingness to be randomized data.
Okay.
And I certainly know that if the options are presented to a patient with true equipoise, many patients are going to refuse to have the open procedure. That's just going to be a fact.
Yeah,
So
it is.
We're going to have an as randomized and as treated analysis. That's clear to me. I would guess that 50% or less of patients presented with the randomization option will select that. So, yeah, we're going to need. My estimate is probably 25 centers.
Okay.
If we could have some other countries besides North America, that would be great. We haven't assembled the building blocks yet. We've got to get them all in the peer review literature. Yeah. I think the essential surgical techniques manuscript that Mai has outlined is going to be really critical because it has all of the visuals, with the in video of how to do the setup, where to place the portals, how to inject the calcium phosphate cement, et cetera, et cetera, and will be very helpful for conducting the trial.
Great. Yeah, you mentioned actually, and that came up to me as well, is in some of these split to press, when you lift it up, you are using calcium phosphate as your recommended filler, so to speak. Okay.
Yes. Yeah, that's all of them that we've done have had that calcium phosphate cement underneath.
Okay, got it. Okay, that's very good. I don't see a lot of questions, so I don't certainly want to pull people into it. Did you have any other comments or I guess I think we've made the argument that there's certainly quite a bit of potential here. The outcomes, it looks like, pretty obviously look like you should win on a number of these outcomes. I would think pretty obviously. If you were thinking of a single primary outcome, and I wonder if you've asked patients that. It's always funny what we think is important, not always what patients think is important. Like, remember going back to that study, Marc, that we talk about all the time around hip fracture care. And while surgeons were worried about reoperation, patients were worried about blood loss and incisions and a bunch of other things that we wouldn't have thought would be anywhere near at the highest level. Largely because a reoperation makes the surgeon feel bad, and a small incision and blood loss for some reason is really important cosmetically to the patient, or at least the incision size was. So I wonder if you've thought about just the types of outcomes that might be important if you had to pick the outcome of interest, because there's so many here that will be that you could pick. Any thoughts on what would be the outcome?
Faster recovery.
Yeah. Okay. And that fits nicely in with the whole issue of in the age of COVID, getting patients in and out of hospital quicker, and certainly recovery remotely is a big deal. Can you talk a little bit, actually, Mai, about the post-operative care associated with this relative to maybe the standards, for open procedures?
So, that's an interesting question because, when I was doing the meta-analysis, it's very interesting that I see a lot of data coming out of China currently. So I think there's also a bit of interest outside of the United States, but the protocols are very different. It's hard to translate. So for us, this is largely an outpatient procedure. Patient go home on the same day. And I expect them to start range of motion right away, and they have a hinge knee brace with them, and expect them to get full range of motion and full weight bearing at 6 weeks. So that's the pretty fast recovery. So I think to answer your questions, I think we're going to have to measure. It's going to be the most significant difference between the two groups in improvement for the scope group is going to be that early recovery, and we have to measure that within that 6 weeks before that 3 months.
Got it. Okay, that's great. So I wonder if we can. I see a couple of questions. Well, first of all, let's address the one from Joseph. Joseph, did you want to raise that? And then there's a few other questions here.
Yeah, sorry. So just to slightly derail the conversation a little bit, I must admit I come from more preclinical background, and in my world, before we do any procedure, we test on mice, and it's very easy to sort of trial and error these things. I guess my question is, when you're trying to teach people an entirely new technique, it seems difficult to convey all those aspects through a paper, and I wonder, does it require sort of if you need these dedicated efforts for recruiting people to train them, and do you see complications with COVID? And I don't know, how can you use technology to sort of improve that aspect with VR and AR? I guess, strategically, how do you actually even get people to reasonably uptake this procedure when it's very, from my perspective, it would seem very, risky to try something new.
Okay, so I'll jump in there because I know what Mark and Mai are thinking. So one thing is, Joseph, I would say that that multiple times I think Mai said, because I was asking, is this novel or new? But really, in training, doing a knee arthroscopy is considered bread and butter training. So it's not necessarily novel. You have two things that are very standard, but I think what's novel is you're bringing them together in a slightly different way. So I wouldn't consider this at all experimental, like some new biologic or something like that. And I'm happy for Mark and Mai to add any more context to that.
Okay.
Mai, I'll let you take that.
I agree with what Mo just said. I would want to add one thing. I think, Joseph, you are right. The risky part of this randomized control trial, I'm a believer in it. That's why I want to present the evidence. But I think the risky part is to trying to get those surgeons to buy in. So it's kind of the vicious cycle, right? You're trying to get the surgeon to do the right thing, to do the best possible technique for the patient to gain the optimum outcome. But at the same time, in order for them to do that, you need to present the evidence, support them to do that. And right now, all the evidence is pretty low level. So I think, what we're trying to do in the process at the same time to trying to build the randomized controlled trial is exactly through meetings like that, to trying to get the information out there to surgeons and provider to introduce the techniques, to publish on this technique so that we know what we already know. Because what happened is that, trauma surgeon, become very focused on fracture and not branching out to techniques that are advanced in other fields such as sports. So I think that if we just keep that tunnel vision, then the risk that, it's going to be hard to try to get 20 centers to adopt this technique on. So we're trying to increase awareness among surgeons right now. It's exactly what we're doing, like you mentioned.
Well, that's good.
One final comment, Joseph. 4 of the top 10 procedures in orthopedic surgery are arthroscopic. So people leaving training today really know how to use an arthroscope.
That's very good.
I appreciate that.
I'm going to go backwards here. There's a question here from Hemant Shirali. Hemant, do you want to come on video here if you don't mind, and maybe just ask the question directly, both to Dr. Swiontkowski and Nguyen? So we can't hear you. I think you're muted.
Can you hear me now?
Yeah, we can.
Yeah.
Oh, okay. Thank you, Dr. Swiontkowski. That was an amazing presentation, and thanks to Dr. Mai as well. I would love to try something like this.
Yeah, we're just missing you. Yeah. Yeah.
My concern is in a knee with an acute injury where there's a lot of blood. Do you need to use an arthroscopic pump initially to clean out the knee and get better visualization? And if we do use a pump, is there any concern with fluid leaking out into the soft tissues?
Right. Yeah.
One.
So we use a pump on every case. We start with pressure at 35, and we can go up to 45. Every textbook that's ever been written on tibial plateau fractures talks about the risk of compartment syndrome. Mm-hmm. We've done well over 100 now. I've seen nothing even close to it. And I would also point out we don't use tourniquets. The only time I've ever used a tourniquet is in a patient that had lupus, that had a massive synovitis, that we had to really do a lot of shaving of the synovitis to be able to see the articular reduction. that was the only case we ever inflated the tourniquet.
Thank you.
Yeah.
And the second question was, my concern would be if I was trying this for the first time in the operating room, what would be the chances of bailing out to an open technique if I get frustrated with the time I'm taking with the arthroscopic part of it?
Yeah, I don't think there would be any issue at all with bailing on it. As a matter of fact, my recommendation to you would be to simply ask for the arthroscopic equipment to be brought into the room, and then take a look. Make the 3 portals and see if you can see the articular reduction, and then go ahead and do your standard open procedure. That will get your comfort level up, that you'll be able to visualize. I would recommend you do that first. Go with your standard plating until you get more comfortable with it. Then try the remaining steps to elevate the fragment with the fluoroscope.
Thank you. Thank you. That's a great point. Yeah, thank you.
Just a quick point overall on OR times. Big difference between times as you kind of once you're comfortable with both. Well, when you're comfortable with the arthroscopic approach, does it add a lot more or less? Faster.
No, it's faster.
Yeah. I figured as much. Okay.
That's a great question about the time. When I started doing it, I was worried that I would take longer because adding the scope time. But what happened is I don't have to close a big incision and put in a femoral distractor and struggle trying to see in the back. So it's actually saved time when I start doing the scope.
Oh, that's great. We have a couple more questions that I'd like to get to. So there's one from Laura Cruz. Laura, I don't know if you're near your computer that you can actually come on video and ask the question directly. If you don't mind, that'd be great.
Yeah, no problem. Thank you. It was a great presentation. Both of you, all of you, thank you. I'm a primary care sport doc, so I love to hear about surgery because I used to love being in the OR, but that's not in my life right now. But post-operatively, is there any difference in the first 6 months in terms of physio needs, functional recovery? You gave us some data about weight bearing at 6 weeks, but what about functional recovery and the need for physio? Because of course in Ontario and other parts of the country, this is self-paid. If the patients have benefits, that's great. Many do not. In my office, probably 60% of our patients are paying out of pocket. So any thoughts or any data on that just yet? Thanks.
Yeah, thanks for that question. I'm going to give you a little bit more detail on the post-operative. So we put the patient a double 6-inch ACE over some soft dressings, and the hinge knee brace is set at 0 to 20. And we tell the patient at that point, foot touch weight bearing. When the stitches come out at a week to 10 days, then the hinges get open. And I tell the patient, you've got 3 weeks to show me a perfect straight leg raise and 90 degrees of flexion. And most of the time they can do that. Extension seems to be harder to get than the 90 degrees of flexion, a full complete extension. At 4 weeks, we throw the brace away. We send them to physio, tell them they can begin to bear weight. Usually by 12 weeks, they're back to all activities of daily living. And we've had a few athletes, I showed you that one football player, that have actually returned to play at 6 weeks. That sounds crazy, but it was really important to this young senior. He wanted to play the last 2 games. He was a captain on the football team, etc. So it is a pretty accelerated rehab. I don't think you absolutely have to have physiotherapy in a highly motivated patient that will listen to you and follow your recommendations. I usually encourage getting on an exercise bike by 6 weeks and working really hard on spinning at first, no resistance, and then at about 8 weeks, starting to add resistance to get your quad back.
That's extremely detailed. That's wonderful. I wonder also that there's a related question from Alexander. Alexander, again, if you're near and you can get on video and you want to ask that question directly, that'd be great. If not, we can certainly ask on your behalf.
Hey Mo, thanks for taking my question. And Dr. Swiontkowski, Dr. Nguyen, thanks for a great presentation. My background is sports, and I was impressed by your weight bearing state. So can you comment more on that?
Yeah, so we're down to, we started with 6 weeks foot touch. Now we're down to 4, and I've not seen any loss of articular reduction or subsidence with letting them bear full weight at 4. It's like anything else. Many patients are non-compliant and they bear weight much earlier than we ever advised. It's the same way we're going with ankle fractures now, with telling patients bear weight when you're comfortable. I think with this injury, it's going to be the same thing. I would predict the way we're going, that's going to be the instruction 2-3 years from now. Bear weight when you're comfortable.
I have to tell you, I was scared the first time I did it. Dr. Swiontkowski encouraged me. But what happens when the patient come back to see me? She wanted to do it, and I can tell that she was going to do it no matter what I tell her that visit. She told me my leg feel normal. So I think, for people who kind of scared and not know what to do for the first patient, like the patient tell you how they feel, and then it give you the confidence to let them wait there early.
Yeah, the calcium phosphate cement has excellent compression strength. And we've got 2 randomized trials in open surgery to show that the subsidence is much less with that compound compared to allograft or autograft. So I think we can be pretty aggressive with this construct.
And Mark, I mean, just from the point of view of epidemiologic studies, when we talk about the significance or clinical importance of a 1 or 2 millimeter step, in the tibial plateau, I mean, has there ever been demonstrated data that really correlates that with outcome, that has been meaningful data that you believe anyway? I mean, I'm not saying it's happening, but let's say it was.
Right. Yeah, no, I don't know of any data that can correlate that amount of articular depression or step off with a functional outcome.
Yeah.
I think you and I and most people on the call know it's more important what patient the fracture is in than what the fracture looks like. So
Yeah.
A highly motivated patient is gonna make the best of a suboptimal reduction. That's for sure.
Absolutely. I think we've got just one more comment here. Are you aware? This is from Frank. Frank, I don't know if you want to come on video. If not, I can certainly ask the question, but it's related to using biologics around for cartilage defects. If you've had any experience with and maybe Frank, I'll let you speak to it. Hi.
Hi, thank you. It was a wonderful presentation. Yes. Many years ago at McMaster, I did some studies on cargel for restoring articular cartilage, and we got some remarkable results from that. And I wondered if we're using it now in Cayman, where I live now. Have you had any experience with that? And do you think that might help to smooth off any irregularities in the cartilage surface when you've restored it?
I have no experience with that, but as this technique evolves and become more mainstream, I think people will start to investigate that, because particularly in the older patient, after you get it restored, it looks perfect on the X-ray, but boy, the edges of the cartilage fracture look awful. So I think that would be something that would require future investigation, but I would think it would be something to do.
Lovely. We're getting close to, I think, the end of this particular session. I just want to make sure if anyone else has any additional follow-ups for Dr. Nguyen, Dr. Swiontkowski, if you want to go ahead and let us know. If not, then what I may ask is for maybe both to give sort of just a closing statement. If you're here helping and encouraging people to consider this approach, Mai, what would be your closing argument to help people really rethink this approach? I think you've done a pretty good job with the presentation, but I figured a closing helpful argument may be also in our best interest.
Yep, I would say the technique is pretty easy to do. The learning curve is not that big, and the outcomes will blow you away.
Pretty compelling. You don't need a randomized trial.
Yeah, we do.
You can just take my word for it.
Yeah, just take my word for it. Yeah. Mark, anything? Maybe up the final comment.
Yeah, well, somebody as old as I can be open-minded enough to go down this pathway. I think all of you young trauma surgeons should have a go at it. You all know how to use a scope, and you'll be impressed. And I even told Mai, and she really pushed back on this. My prediction is 15 years from now, we'll be doing pilon fractures the same way, with an arthroscope and moving the fragments around and doing percutaneous fixation. because the soft tissue whack is where we get a lot of the complications and delayed recovery. So be open-minded. Don't be an old fart.
Wonderful. What a wonderful way to end. Nice discussion, nice debate. It seems that there are lots of people asking to come visit you now too. So therefore, you'll have lots of guests. I would encourage you, and I would encourage those of you who want to take a look at this video again. We'll have it posted soon. We'll have the notes with this as well, and we'll make sure we provide email address for Mai, so you can contact her if you want to get more information. So to everyone, have a wonderful evening. Thanks to you again, Dr. Nguyen. Of course, Dr. Swiontkowski, lovely to see you again, and we will chat again soon, I'm sure.